Good morning to everyone. Let's start our today lesson. There are two topics left to discuss. All of them are from the rheumatology. Today we will speak about osteoarthritis, and at the following lesson we will discuss gout. And then our scheduled topics will be over, and we will have just two optional lessons to get more experience for your exam. I hope that you have listened to the lecture, because there is a video lecture. And you see that rheumatology, or a branch of science that studies disease of muscles, joints, and connective tissue, is a very large area that includes a lot of diseases. At our course, we will study only two of these diseases, osteoarthritis and gout. At the next year, during the course of hospital therapy, you will study autoimmune diseases, such as rheumatoid arthritis, systemic lupus erythematosus, and some else. Reactive arthritis will be mentioned in the course of infectious disease, as they are typical for different infections. Psoriatic arthritis is a part of the psoriasis spectrum, and it will be studied at the dermatology. Osteoarthritis is a very common disease. This is a very careful figure, 20%, because it includes the adults of all ages. And the prevalence increases with the age, and you see that almost all people, all elder people over than 70 years will have some degree of osteoarthritis. However, do not make a mistake and do not say that osteoarthritis is an age-related disease, because age itself does not cause any disease. Previously, in some countries, osteoarthritis was called osteoarthrosis, and you may find this name in some papers and publications. But in the recent years, the intrinsic inflammatory mechanism was confirmed. That's why the term osteoarthrosis is not correct, and the name osteoarthritis was adopted worldwide to underline that it is not just only degenerative disease, but it has inflammatory component. You see that definition is somewhat unclear. Disease due to imbalance between the process of destruction and restoration of the joint tissues. And indeed, there is no one clear cause and one distinct pathway to be addressed. It is a multifactorial disease. Some genetic predisposition plays some role, and different trauma, and the term imbalance itself is somewhat broad, because the same state may be a good balance for one person and an imbalance for other person. And you see that it is resembling our discussion about inflammatory bowel disease, somewhat unclear, but without clear cause and without distinct mechanism, and difficult to treat. This is true for all multifactorial diseases. It seems that we know a lot about them, but this large knowledge does not help us to treat, to cure this disease and to help patients. Briefly, osteoarthritis is a destruction of the joint cartilage due to interaction of multiple factors. Genetic predisposition means that the resistance to trauma is decreased, and multiple microtraumas will cause the more fast destruction of the cartilage tissue than compared with patients without genetic predisposition. Repeated trauma means that sport activities is a risk factors. And you may say, what's wrong? We have spoken so much that the sport is good, and we advise patients to perform physical activity, and now you are saying that sport will damage our joints. This is true, and we should differentiate the great sport or professional sport and physical exercises to that help our body to be healthy. Mild to moderate physical activity is good. That's why when we have discussed recommendations to patients with chronic cardiac and chronic pulmonary diseases, we have said that physical activity should be comfortable for the patients. No one should overwhelm his or her possibilities to do as much activity as possible. In contrast, professional sport activities are overwhelming in their nature. The people should do as much as they can, and in sometimes even more than they can, to get the best results. This overwhelming physical activity will, in fact, damage the tissue. That's why professional athletes usually develop osteoarthritis after the age of 30, and some of them have signs of osteoarthritis at the second decade of their life. So if someone wants to be a professional athlete, all benefits and risks should be weighed. If you look at these risk factors, you may note that many of them are common for many chronic diseases. Age itself is not a cause for any disease, but with age, a progressive degeneration of different tissues occurs with fibrosis and calcification, and the rate of degeneration decreases. So the age is a predisposition factor for development of different chronic diseases. female sex is a risk factor. Obesity and overweight, it is understandable because the more a person is weighing, the more is a burden to the joints, especially joints of the lower extremities that are more commonly affected by osteoarthritis. Injuries, we have discussed them, and some occupational factors that increases the burden for the joints, such as working with the vibration instruments and lifting heavy things at work. We classified osteoarthritis for primary and secondary, but in fact, the primary or idiopathic osteoarthritis is very rare condition because every human have microtraumas since the birth, as the baby begins to walk and fall, and every fall is a microtrauma to different joints. That's why almost all cases of osteoarthritis are classified as secondary. In fact, you cannot find anyone who had no trauma during his or her life, except some people who are disabled since the moment of birth and cannot move at all. But in these patients, osteoarthritis will be the least problem among all others. Please note this paragraph. This is a very common mistake when different doctors diagnose rheumatoid arthritis and osteoarthritis as mutually exclusive conditions. And many doctors think that if patient has osteoarthritis, he or she cannot have any other arthritis. This is not true. This can be concomitant diseases in one person, and the patient may have gout, rheumatoid arthritis, and osteoarthritis simultaneously. So just gather a history and make appropriate investigations. And if you see both signs of gout, for example, and osteoarthritis, you should diagnose both of these conditions. If you see signs of rheumatoid arthritis in the hand joints and signs of osteoarthritis at the knee joints, we will diagnose the rheumatoid arthritis with the involvement of the hand joints and knee osteoarthritis in the same patient. In this slide, the complex mechanism is explained. I think that you have listened for the professor when he's explaining this slide. Briefly, the interaction between internal factors and intrinsic factors leads to cartilage destruction, and destruction causes secondary inflammation that in turn increases the destruction of the joint tissues. And this process leads to two groups of signs and symptoms: bone symptoms, osteophytes and sclerosis, and damage to the joint capsule such as fibrosis and calcification. This is a scheme of progression with the X-ray images. But pay attention to the moment that X-ray changes, X-ray grade and symptoms may not correlate. The patient may have very little changes, for example, initial stage of the osteoarthritis and very severe pain. And on the other hand, the patient may have almost destroyed joints and no pain at all, only gait disturbances. And we should treat not X-ray findings, but a patient. If a patient has severe pain and the pain was a cause for his or her visit, and you perform an examination and find only mild degenerative changes, do not say, oh, it's good, your joints are almost healthy, so wait and the pain will subside. No. You should treat both signs and symptoms. So even if the joints seems healthy, treat the patient to relieve his pain. You see that, as we have said, joints of lower extremities are involved most commonly, as they have to wear the whole weight of the body during walking and running and standing and jumping as well. Hand joints are the second joints that are involved in the osteoarthritis. Spinal joints are involved in almost in all patients, because you can find osteophytes at X-ray in all elderly patients, but spinal joints osteoarthrosis rarely cause symptoms itself due to the construction of the spine. Complaints for the spine are usually caused by neurological diseases. You will study them if you are not studying them concomitantly with our course. Due to intervertebral disc protrusions and some nerve diseases, but bone involvement rarely cause symptoms. Symptoms in osteoarthritis are relatively typical. Mechanical pain. You remember that there is a slide with differentiation between mechanical pain. So mechanical pain is a pain of movement. It is associated with the physical exercise and progresses along with the activity. The eye is afternoon, but at night, when the patient is at rest and has no activity, mechanical pain does not recur. The patient may have starting pain after a period of rest when he or she begins to perform activity, but this pain will subside soon we say that the patient has walked up his joints. If the patient has morning stiffness more than half an hour, this will be a sign of rheumatoid arthritis, one of the diagnostic criteria. Of course, destruction of the joint will cause loss of motion, and progressive destruction results in joint deformation. The joint tries to compensate this destruction and increased load. That's why bony enlargement are found, such as Heberdens and Bouchard's nodes. Contractures develop, and because due to loss of motions and involuntary attempts to help the joint and to reduce the load, muscle atrophy develops. You may find crepitus during palpation, and tenderness is a sign of inflammation in the joint. Here is the slide about inflammatory and mechanical pain. Typical osteoarthritis hands. You may have noticed such hands in your elderly people in your country and in your town. If not, look at the elder people, at their hands and at their gait. You see that the joints are deformed, distorted, and there are some bony prominence. These are Bouchard's and Heberdens node. The difference is only based on the location. Nodes over the distal interphalangeal joints are called Heberdens nodes, and nodes over the proximal interphalangeal joints are called Bouchard nodes. As osteoarthritis is a degeneratively inflammatory process, there are no specific lab parameters to diagnose osteoarthritis, and we should never prescribe lab analysis to diagnose osteoarthritis. Instead of this, we may prescribe lab analysis to exclude or confirm other conditions when the complaints are unclear and we cannot be sure that the patient has only osteoarthritis. We prescribe lab analysis to differentiate between osteoarthritis and other types of arthritis, such as rheumatoid arthritis that has specific lab parameters, ankylosing spondylitis, and some reactive arthritis that are most commonly infectious. X-ray is the main method to confirm the diagnosis of osteoarthritis, as we can find the typical bone and joint changes. The cartilage is destroyed, that's why joint space is narrowed, and the more cartilage is destroyed, the more narrow will be the joint space. And of course, this joint cannot move as well as usually, and this progressive narrowing of the joint space will cause progressive loss of motions. We may see osteophytes in this X-ray. Osteophytes are not visible very good. The osteophytes are the best visible at the spine X-rays. You may see subchondral sclerosis, that is looked like as a white band just under the border of the joint, and you may see the bone incised, for example here, that are hypolucent areas. Based on the X-ray finding, you may classify osteoarthritis by different grades. Grade 0 means that the patient has typical symptoms and maybe signs during physical examination, but no X-ray changes. This is the early stage of the osteoarthritis, and implementing of the lifestyle changes may significantly delay the progression of osteoarthritis and delay the bone and joint destruction. Grade 1 is a doubtful joint space narrow, such as, this is not grade 1, this is grade 2. So there are, for example, here, we can, the joint space is somewhat narrowed, but we cannot say that it is severely impaired. So we see changes, but they are not very prominent. When we see definite osteophytes and joint space narrow, that mild to moderate, on the weight-bearing radio X-ray, not in the supine position, not in the sitting position, the patient should be stand up, to exert weight bearing on the joints of the lower extremities, and we should assess X-ray only in this position. When we see multiple osteophytes, sclerosis, and clear joint space narrow, this will be grade 3. Most of your patients will have this grade. And severe joint space narrow, bony deformities, and severe sclerosis indicates the grade 4 or the last stage of osteoarthritis. So let's look at these X-rays. We see joint space narrowing, some degree of sclerosis. Look at the bony dents at here and here, and you see the in this part the bone is more dense than here. This is a subchondral sclerosis. Sclerosis, definite joint space narrow. This is grade 3. We should not obligatory have all the listed findings. For example, the patient might have definite joint space narrow and sclerosis, and this is enough. We do not need to find osteophytes, because osteophytes are found not in every joint. And the patient might have osteophytes and joint space narrow without bony deformity. This is enough to diagnose the grade 3. This X-ray, you should always perform X-ray of both joints, not order the X-ray of only the joint with complaints. Make X-ray of both joints and compare both right and left knee, both right and left hip. So in this X-ray, we see that this joint space is smooth and equal, but here this is the right hip and this is the left hip. We see the definite joint space narrow, sclerosis, and here we can see osteophyte, small osteophyte. So this is again grade 3, definite joint space narrow, sclerosis. Subchondral sclerosis. When we see the white matter on the X-ray near the joint space, this will be the subchondral sclerosis. If you look at this interphalangeal joint, you may see that in some fingers, joint space is absent and there is something unclear mass in these areas. This is the full destruction of the interphalangeal joints, and there is complete loss of function in these joints, such as this. Here we can see a subluxation. This bone is shifted laterally relative to this point. Look, please. The axis of the joint is impaired. So this is a grade 4 osteoarthritis. At this X-ray, we see osteophyte, sclerosis, and definite joint space narrow. You see that the joint axis begins to deviate, but no subluxation has developed. So this will be a grade 3 osteoarthritis. Osteophytes or bone spurs are very poor visible in the hip, but we look at the other signs. Here we cannot trace the joint space, obvious joint space narrowing, and here we see a white matter, so this is a subchondral sclerosis. Grade 3 osteoarthritis. Spine. In the spine, you can see osteophytes almost in all elder patients. Here, 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 and here, and you see that borders of the vertebrae are seems underlined by the white. This is also a subchondral sclerosis, but we cannot see any joint space narrowing. So this will be definite osteophytes, grade 2 osteoarthritis, because we can see definite osteophytes, but no joint space narrowing. Bone-sized are the areas of liquid formation, and they looks like a dark or black areas on the X-ray. Sclerosis is an area of the dense bone tissue, and it is visible like a white area. And sized are the area of the poor, of the decreased bone density. That's why they look like black areas. We see bone sized here and subchondral sclerosis as well. We let's trace joint space, somewhat narrowing here. So this will be grade 3 osteoarthritis. As for this wrist, we can see sized here and here, and very mild subchondral sclerosis without any joint space narrowing, grade 2 osteoarthritis. Some mnemonic rules to help you diagnose the osteoarthritis of the hand: inverted T sign and flying gull sign. These signs are caused by the subchondral sclerosis of different joints. The flying gull sign is more common than inverted T sign, and it is more readily visible. Please look at this joint and we can see osteophytes. They may be palpated as Heberdens nodes. Let's find any signs, any other signs of osteoarthritis. Osteophytes here on the third finger, and unclear osteophytes in the fourth finger. Look, please, here the joint seems destroyed. This was a bone incised that destroyed over time. Osteoarthritis of the key, this will be the majority of your patients, as the key and the hip are the two joints that are most commonly affected by the osteoarthritis. Here we see possible joint space narrowing, but subchondral sclerosis. Here we see subchondral sclerosis, joint space narrowing, and bone incised here, here, and unclear sized here, and osteophyte. And here we see obvious joint space narrowing, sclerosis, and subluxation. This joint is immobilized and the patient cannot walk without help. Osteoarthritis of the hip. Here we see obvious subchondral sclerosis here, sclerosis and joint space narrowing here and here. Here we see clear joint space narrowing and begin early stage of subluxation. And here is the grade 4 subchondral sclerosis, joint space narrowing, bony deformity, and osteophytes. These rays are from different patients. They are not the sequential X-rays of the same patient. So do not try to trace the disease progression. This is different stages of disease in different patients. We have discussed that the signs and complaints may not correlate. And in the primary care settings, if you are a general practitioner and you see the elder patient with typical symptoms and movement restriction, maybe crepitations during palpation, you do not need to perform X-ray. You may perform X-ray to exclude other causes and to classify the grade of osteoarthritis, but this is not necessary. Similar to the gastroesophageal reflux disease, please remember, if we see the patient with typical complaints, we do not need to perform examination. Yes, what? You have raised a hand. So, similarly, in the patient with osteoarthritis, you may start empirical treatment if the condition is clear for you. Other diagnostic tools are helpful to find other causes or complications, or maybe some factors that cannot be cured, such as post-traumatic osteoarthritis. We can perform arthroscopy for debridement and to correct, and for example, for the joint arthroplasty. Here is the views from arthroscopy. We can see joint space and a lot of fibrin deposits. If you want to get acquainted with the arthroscopy, you should just join this practice and view arthroscopy in real life, because it is very hard to train this method by the slides and by the videos. Diagnosis. And again, if you perform X-ray for other reason and you find signs of X-ray signs of osteoarthritis, but the patient has no other symptoms and signs, you should not diagnose osteoarthritis. Please remember our lesson about the pancreatitis. We have said that if you perform an abdominal ultrasound and you find the changes of the pancreas parenchyma, you should not diagnose the chronic pancreatitis without signs and symptoms from the patient. This is true for the osteoarthritis. No signs and symptoms, no diagnosis. We do not treat X-ray, we treat a patient. This is especially true for the spinal changes, as a lot of patients will have osteophytes, but only a minority of them will have associated signs and symptoms. So if you have a patient with lung complaints and you perform a chest X-ray to diagnose the lung disease, and you, additionally to the lung findings, you find osteophytes in the spine, do not make a diagnosis of spinal osteoarthritis unless the patient has appropriate signs and symptoms. You have noticed from the lecture that the basement of treatment includes a lot of lifestyle modification. So because we do not have any heterotropic treatments, as this is an age-related degenerative process. We do not have any pathogenic treatment because we still don't have any evidence-based medicines to restore the damaged cartilage in the joints. We can only slow the progression and alleviate the symptoms. And as the osteoarthritis is a multifactorial disease, we have a lot of ways to reduce this, the role of these factors. But as in every disease, the more factors we have, the less effective will be our treatment will be. Of course, patient education, we should explain what osteoarthritis is, what are risk factors, and how the patient should behave to reduce the risk of progression. We cannot completely stop the progression. The cartilage will continue to destroy, but we can slow this process. Obesity is a very significant risk factor due to increased load on the joints. That's why we should recommend weight loss. Simply to say, but very hard to implement. Some patients will need a help of dietologists and psychologists. So we cannot just say eat less foods and everything will be good. No. Very difficult recommendation for the patients. Exercise programs, but remember that strenuous activities will be harmful. So we should maintain a balance between healthy activity and harmful activity. Physical therapy. Please note that in different countries, there may be different definitions of physical therapy. In some countries, for example, in Russia, physical therapy was historically included some non-evidence-based methods such as ultrasound, heating, electrophoresis, and other unclear methods. So they may be confused when defining what does it mean. So physical therapy is a special rehabilitation exercise program under the supervision of the physical therapist. The program of exercises should be individualized, and ideally, every patient with osteoarthritis should be referred to the physical therapist to find the individual program and for education how to perform these exercises properly. And after the education, in the physical therapy, the patient may be discharged to make these exercises at home. Because if you just recommend exercises, for example, see or find a complex in YouTube and just repeat. This is a bad practice because the majority of patients are not able to perform these exercises properly. So physical therapist is a good practice for patients with osteoarthritis. In severe cases, some patients need assistive devices for ambulation because they cannot walk without these devices. Taping do not have enough evidence, but it may help in many patients just due to some grade of fixation of the joint. Appropriate footwear is very important, especially in females, because many females prefer to wear beautiful footwear instead of useful and safe. We should educate the patient and explain that inappropriate boots, inappropriate shoes will cause damage to the joints and will exacerbate the osteoarthritis. In some cases, bracing and occupational therapy will be needed, such as joint protection to avoid the excessive burden. Here is a workplace of the physical therapist. Rehabilitation, education, and the patient will be ready for the ambulation and for performing the exercises itself, him or herself. Drug treatment are designed only for symptoms relief. The first line drug is paracetamol or acetaminophen. This is the same drug, only different names in different countries. It is well tolerated, but please do not forget the safe dose. Please remember the pharmacology course. The daily dose of paracetamol is 4 grams or 4,000 milligrams. The usual tablet of paracetamol contains 400 milligrams. So the maximum daily dose is 8 tablets per 500 milligrams. No more, because in higher doses, paracetamol is not longer safe. It can cause irreversible toxic hepatitis, that is a life-threatening condition. You know that paracetamol is a very rather common drug to treat pain and to treat fever. So even if you treat a patient not with chronic pain, but with common cold, always explain that the paracetamol has the maximum daily dose that should never be exceeded. If the paracetamol is not completely effective in this dose, another drug should be added, but no additional tablets of paracetamol. This is very important because we see 1 or 2 patients with toxic hepatitis due to paracetamol every year. Most commonly, these are patients who treat fever in the common cold, and in the cases of flu, they just taking tablets or taking over-the-counter remedies, combination remedies that contains paracetamol among other ingredients, and they do not look at the dose that leads to dangerous complications. Please be careful yourself and educate your patients. But the recent analysis showed that the effectiveness of paracetamol is close to placebo. However, as the osteoarthritis is a chronic inflammatory condition, even placebo effect will be good. If the patient benefits from taping, do not begin to tell that placebo is no, that taping has no evidence and it cannot be recommended at all. No. If the patient is using a safe method that has no enough evidence, but he or she benefits from this method, this patient should continue to use this special thing. Because if the patient has placebo effect, this effect allows to reduce the need in pain relievers. That all of that has definite side effects. Another drugs, NSAIDs. Paracetamol is not an NSAID. This is a separate drug. It is not included in the class of NSAIDs. A lot of them. You may prescribe any drug that is available in your country and that is helpful or effective in this particular patient. The effects may be different. Some patients may benefit from nimesulide, and some patients love meloxicam. Very good. The first patient should take nimesulide, and the second one will continue to take meloxicam. Ketoprofen and ketorolac are highly effective, but a lot of side effects preclude their use, for their regular use, and they should be reserved only for severe cases and for short-term treatment, such as prokinetics in the gastrointestinal disease. A lot of side effects, so just short-term treatment in lowest possible doses. COX-2 inhibitors, COXIBs, celecoxib and etocoxib are very effective, but if you read medical news, you may have noticed that there are a lot of studies the adverse effects of COXIBs on the cardiovascular system. The first study has found that COXIBs increased mortality in the cardiovascular patients, and their use was restricted. Then another study have shown that there is no additional mortality in this patient, and the COXIBs were rehabilitated and were reintroduced in our practice. So there are different studies that are ongoing and examining the COXIB effects in the cardiovascular patients. Nowadays, we can say that you may prescribe this drug to patients with chronic cardiovascular disease, but with cautions. And if you can choose another drug, prefer another drug to the coxib. All NSAIDs inhibit cyclooxygenase and inhibit the synthesis of inflammatory prostaglandins. Non-selective NSAIDs that inhibits only cyclooxygenase 2 affect only this way and inhibit the synthesis of inflammatory prostaglandins only, but non-selective NSAIDs, all of this, inhibits both types of cyclooxygenase, so they exert both useful effects and side effects. The most significant among this effect is gastrointestinal damage and increased risk of bleeding. A very common situation when the patient comes to you for the first time, you diagnose osteoarthritis and just prescribe NSAID without asking about concomitant medication. Very common mistake or very common omission in many patients, because many patients are already taking another NSAIDs to treat another condition. For example, if you see the elder patient, it is a very high probability that this is a patient with the coronary heart disease that is taking aspirin. And if you just prescribe another NSAID, your NSAID will add the risk of gastropathy to the aspirin. The same is true in patients with peptic ulcer disease. So do not forget to ask about concomitant medications and medical history. Because if the patient has no additional risk factor, you may just, and is taking no other NSAIDs, you may just prescribe, for example, nimesulide without any other drugs. But if the patient has a history of the ulcer complication, you should not prescribe NSAID without the help of PPI. If the patient is taking another NSAID, for example, he's taking diclofenac to treat another painful condition, you should not just prescribe another NSAID to treat his osteoarthritis pain. You should change his diclofenac for another NSAID, because diclofenac is obviously ineffective for the osteoarthritis pain, and you should not add the risk. Change this ineffective drug to another drug that allows to treat both osteoarthritis pain and the concomitant painful condition. Be very careful when you prescribe NSAIDs. Here is the NSAID gastropathy. And in contrast to the peptic ulcer disease, NSAID gastropathy is almost always asymptomatic. So the patient will have chronic or recurrent bleeding, and will not know that he has damage of the gastric mucosa. All NSAIDs will exert their side effects independently of the route of administration. Both oral formulations and parenteral formulations will inhibit both types of cyclooxygenase. So you should not prefer parenteral form over the oral form in an attempt to protect gastric mucosa. It doesn't work. So hidden belief we have discussed, and a lot of other side effects. Nephrotoxicity, toxicity, hepatotoxicity, cardiotoxicity, and you know that we should avoid NSAIDs as much as possible in patients with cardiovascular disease, especially in patients with coronary heart disease. It does not mean that these patients should not receive any NSAIDs and they just need to experience their pain. No, the pain should be treated in all patients, but in patients with coronary heart disease, you will need to pay more attention to the cardiac condition. Topical NSAIDs has a very low bioavailability and their effects is doubtful. However, even if the effect is caused by placebo effect, the patient should continue to use if he or she benefits from the topical NSAIDs, because it may help to reduce the dose of systemic NSAID or delayed its administration. Every placebo effect is good in osteoarthritis. If NSAIDs are ineffective, all lifestyle changes has been implemented, and the NSAID, different NSAIDs have been tried, and the effect is incomplete or unsatisfactory. Other analgesics may be used, opioid analgesics, but long-term use is dangerous due to risk of addiction. Usually we prescribe opioid analgesics to treat the exacerbation, and when the symptoms abate, the opioid analgesics are discontinued. In some countries, there is a transdermal therapeutic system of lidocaine that is very effective, but has a short effect. So if you have this system, you may prescribe it to treat the exacerbations. Intra-articular corticosteroids are effective. They do reduce pain and inflammation, but the effect lasts for 4 weeks, and you should not perform corticosteroid injection in the joints more than 2 or 3 times during a year, because long-term use of corticosteroid will exacerbate the progression of the joint degeneration. So you can help your patient for 4 years, but no more than 2 or 3 times. So if the patient per year, so if the patient has exacerbation, first try to modify lifestyle, to adjust another drug therapy, and then you can, if the effect is inappropriate, you may perform steroid injection in the joint, but no more than 2 or 3 times per year. You see that hyaluronic acid injections do not have very strong evidence, but it can be considered in the knee osteoarthritis. They help many patients, despite the enough evidence. If it because the harms are very little and the benefits overweigh the harms. Symptomatic drugs, glucosamine and chondroitin, that are known as chondroprotections, were popular some years ago, and they get a great attention and were used by many doctors, but the mechanism is unclear and there are no strong evidence for their effect. In fact, if you try to study the guidelines and meta-analysis, you will find that chondroprotectors were somewhat effective in relieving the pain in patients with severe osteoarthritis and severe pain, in addition to all other pain-relieving drugs. Unclear evidence. In some countries, they are registered as drugs. In the USA, they are considered as dietary supplements, and in most cases, they are expensive. So you should not prescribe these drugs or supplements. However, if the patient wants to take them for his own will, you should not restrict their use, because every placebo effect that reduces the need in analgesic is good. Some drugs, other pain relievers to address other mechanisms of the drugs of the pain are useful, but these drugs are not useful, and you should never prescribe the homeopathy due to unknown safety, because only the manufacturer knows what contains in the homeopathic drugs. If you review the news, you may find a problem with some of USA homeopathy manufacturers that includes belladonna toxins in the homeopathic drug. By the term, homeopathic drugs do not contain any active substances. That's why they cannot exert the effect. But in that case, the manufacturer has added belladonnas in the pain relievers for the infants to treat their teething pain, and there were several deaths. And the real ingredients in these drugs will not comply with the label, so homeopathy may not be safe as well. A stepwise treatment that I will not repeat after the lecture. Arthroscopic surgery may be beneficial in some patients with obvious post-traumatic osteoarthritis. And the final step of the treatment is the joint replacement. Some doctors ask why we should not make a joint replacement in all patients with osteoarthritis. This is a surgery, a very a major surgery with associated risks. So this method should be reserved only for those patients in whom all other methods are ineffective and their disease impairs their quality of life and impairs ambulation. We have two main variants of joint replacement, for the knee joint and for the hip joint. And unfortunately, many patients will need sequential replacement of the one and then of another joint, because even if the osteoarthritis begins unilaterally, over time it will progress to the bilateral disease. So this is all about theory of osteoarthritis. Do you have any questions while I'm making print screen of your attendance? Oh, almost all of you are here. Very good. Okay, let's move to clinical cases. Clinical cases. First of all, clinical cases. About osteoarthritis. This is your home case. Your answers were brilliant. We see not very old man, 64-year-old male, is an elder patient, but not very old, with left knee pain. He can say that pain is worse when he returns from walking. It is important because this is not a starting pain. This is pain after there's some period of activity. He's walking from his home to the store, then he walks back, and the pain occurs only during the way back, which is a dull ache that is present for the past several months, maybe longer, he cannot recall. This is a typical complaints in patients with osteoarthritis. This is not an acute disease. This is a chronic disease with indolent course, with a slow progression. So patients usually cannot define the onset of the disease. This is several months, maybe several years, I don't remember. Of course, the pain has been present for maybe for several years, but at the beginning it was mild and did not impair the quality of life, and the patients usually do not pay attention to this pain. And some of them think, I'm an elder person, I'm 60 years old, it is normal for me to have knee pains. All people of my age experience knee pain. No, not every of them. That's why these patients with osteoarthritis are living with their disease for months and years before visiting a doctor. And that's why at the presentation, you most commonly will see grade 2 or 3 of osteoarthritis. Here was a motor vehicle accident 3 or 4 years ago with a knee trauma. A risk factor for osteoarthritis. Even if the patient has not had this accident, he has suffered some falls during his life that are only risk factors for the osteoarthritis. No fractures, some pain in his right knee. The right knee was not traumatized in the accident, but it is painful as well. The pain is mild and does not bother him. That's why the patient complains only on the left knee. And you know about the right knee only after the active asking. A very common situation. What are your complaints? I have a pain in the left knee, the patient describes. And you ask, do you have pains in the other knee? Oh yes, when you have asked, I remember that I have a mild pain in the right knee, but it doesn't bother me. So do not pay attention to it. No. Ask about all joints in the body. You see a small effusion in the left knee, no effusion in the right knee, and this explains the difference in the complaints. Both knees are affected by osteoarthritis, but the left knee has additional risk factor, a moderate trauma. Crepitus in both knees. No erythema or wounds, no signs of active inflammation. No ligamentous abnormalities. So what is the most likely diagnosis? Bilateral knee osteoarthritis. Bilateral. Additional test. You were right in your answers. Of course, the additional test will include X-ray. However, the complaints are typical for osteoarthritis, so remember the lecture. In the primary care settings, you can prescribe the treatment without X-ray. We have no suggestions of the other causes. The symptoms and signs are typical for osteoarthritis. So if we do not have X-ray readily available, or the patient refuses X-ray, we do not need to wait the X-ray result to prescribe the treatment. You may perform the treatment immediately. Best initial treatment. All that we have discussed. First of all, lifestyle modifications. There is no words about weight and height. So if the patient is obese, we should recommend to lose his weight. We may recommend taping, as it may help due to placebo effect, and topical NSAIDs. And if our placebo methods will not help, we recommend the real NSAIDs, remembering about the side effects. Long-term prognosis. Be careful with these questions at the exam. We have different types of prognosis. Prognosis regarding the life, prognosis regarding the cure, and prognosis regarding the working capacity or disability. When we talk about the life, of course, osteoarthritis is a benign condition. No one in the world have died from osteoarthritis. So in this aspect, the prognosis is good. Regarding the cure, the prognosis is bad. No one in the world have been cured from osteoarthritis. So the patient will not be healthy, and his condition will progress slower or faster, depending on the treatment effectiveness and the patient compliance. The prognosis regarding the working capacity. We do not know about the patient work, or maybe he is retired. So let's discuss his daily activities. The pain is interfering. He's walking to the store, so the pain is interfering his daily activities. Here the patient and the prognosis will be the same as for cure. If the patient will never be healthy, and he will never be completely free of pain. There will be some periods when the patient will experience no pain, but this disease is waning and waxing, and the patient will never be completely free of symptoms for the long time. So the prognosis is moderate for the working capacities and for daily activities if the patient will be compliant with the recommendation, and if the treatment is effective, the prognosis will be good for some time, but then the disease will progress. Not a life-threatening disease, but disease that severely impairs the quality of life. Do you have questions about this patient? Okay, another patient, the same age, 65 years old, female, retired. Pain in both knees, with morning stiffness about 10 or 15 minutes. Very important to ask about the duration of stiffness, as stiffness more than half an hour is should be a suggestion for the rheumatoid arthritis. At this stage, we may suggest osteoarthritis. Age female, pain in large joints, and short morning stiffness. This pain lasts for 5 years, and the symptoms are provoked by physical activity. Specific sign of the mechanical pain rather than inflammatory pain. During the last year, the pain became more intensive, occasionally locks up, and sometimes occurs even at night. The pain at night indicates the inflammatory component. Please remember the lecture. Every one patient may have several diseases simultaneously. So at this stage, of course, we suggest osteoarthritis, but the night pains are not typical for osteoarthritis. And we may suggest that the patient has some kind of inflammatory arthritis. Height and weight. Please calculate the body mass index. And I will perform the calculation as well. Where is body mass index? Weight, story. 101. Height, 1 thing. Oh, I have the body mass index almost 35 kilograms per square meters. This is a grade 2 obesity, a risk factor of osteoarthritis. Lungs are clear for auscultation. Blood pressure is normal. Heart rate is normal for this patient. Crepitus of the knee joint, bony enlargement, and restricted movements, mostly in the right knee. No redness or swelling. So after the physical examination, we confirm the joint disease. That is more comply with the osteoarthritis, and we see the risk factors and no sign of acute inflammation. Lab results. Normal white blood cells, no signs of infection, and normal erythrocyte sedimentation rate. And serum uric acid is normal. How do you think? Why we have measured serum uric acid? To diagnose what condition? Yes, thank you. We have not studied it, but you know about it. Very good. Yes, we measure serum uric acid to exclude gout, and this is normal. The patient has no gout. Very good. So you have discussed the most likely diagnosis, but tell me please, what additional tests do you want to perform to clarify the diagnosis? All is clear for you, or not?
X-ray.
X-ray, yes. X-ray to find the specific signs of osteoarthritis, or maybe other arthritis, and any other or no? Look, please, in this case, the patient has typical signs and symptoms of osteoarthritis, except night pain. The night pain indicates the inflammatory arthritis, but fact pathogenesis. No. So let's begin with lifestyle modifications, individual physical activity, physical therapy, and recommendations to lose weight, diet revision, activity revision, and maybe referral to dietologists. And as in this patient, we should recommend all safe placebo methods, taping, topical NSAIDs, maybe walking assistant device. We do not know if the patient has troubles with the walking. And oral NSAIDs, any NSAIDs or paracetamol. The prognosis will be the same. This is not a life-threatening disease, but this is a disease that impairs quality of life, and patient compliance, losing weight, regular activity, and all the pain relieving methods will slow the progression and improve quality of life, but will never cure this patient. Maybe eventually both of these patients will progress to the stage when a joint replacement will be needed. We cannot say this at the presentation. Do you have questions about this patient? If no, let's discuss our home cardiology case. I was very glad to receive your answers. They were excellent. Case. Okay. Please look at this case. An old man, 79-year-old man, is brought to the general practitioner by his daughter. He did not want to visit the doctor himself. The doctor says that he is tired and has apathy, without interest in life. General malaise for the last 6 weeks. And maybe this patient have lost a few kilograms over these times, but he does not weigh himself regularly. All this history is discussed with the daughter. The patient himself says that he has limited on exertion by tiredness for a year or so, and in some cases he had a feeling of tiredness across his chest. So tiredness. We hear about tiredness from the patient, and we hear about tiredness from his daughter. So the patient is ill for a year, but during the last 6 weeks, the tiredness became so prominent that his daughter have noticed that something is wrong. No other medical history. He smokes a pack of cigarettes a day, a risk factor for everything, and drinks a pint or two of Guinness each Saturday and Sunday. This is a safe dose because when we calculate per week, this will be a very small dose of beer. He does not take any medication and occasionally takes paracetamol. Suddenly, he says that he has lost his appetite over the last months. Occasional nocturia. This is very common for the elder patients. Sleeping at night is an abnormal sign in every patient. No relevant family history. He retired, but he is working with his dog. So let's review the history. Tiredness, progressive tiredness for a year, severe tiredness for the last 6 weeks, unwell. In elder people, our first suspicion should include tumor. In every elder people with new onset symptoms, we should suspect tumor as the most dangerous disease. All these symptoms may comply with the cancer. Let's move to the physical education. No tachycardia, blood pressure may be normal for the elder patient, We do not have history of the blood pressure, so we cannot say if this blood pressure is decreased. No clubbing. So no, the clubbing is typical for the chronic inflammatory disease. Tar staining on the fingers and nails of the right hands. Jugular venous pressure is normal. Apex beat is displaced. Enlargement of the left ventricle or pleural effusion. We here ejection systolic murmur, radiation to the carotids. This is common in elder patients with age-related aortic stenosis. But a soft early diastolic murmur at the lower left sternal edge is an abnormal finding. No other urine traces of blood and some red cells. X-ray heart enlargement. So we have found a disease of the aortic valve. Lab investigations. Anemia. Normocytic anemia. Moderate. Prominent elevation of the white cell counts due to neutrophils and severely increased sedimentation rate. Signs of infection. You should remember that in very old patients, infection is not necessarily associated with the fever. In elder patients, infection may manifest as general malaise and tiredness due to age-related reactivity of the immune system. So these lab findings are significant to suggest an infection. When we analyze the ECG, we see regular sinus rhythm, yes, no arrhythmias, normal QRS, but a voltage criterion of the left ventricular hypertrophy. So we see signs of infection in patient with the heart murmur. This is enough to suspect the infectious endocarditis. Of course, to confirm this diagnosis, we should perform the investigation to visualize the heart valve or echocardiography, ultrasound of the heart. I was very pleased to see your correct answers because this is a rather difficult case for the doctor, and it needs requires a great knowledge to correctly diagnose this condition. So we should confirm the infectious endocarditis and then perform a standard examination, blood cultures, antibacterial therapy, and maybe valve replacement depending on the valve disease severity. So please great attention to your old patients with unclear symptoms, tiredness, malaise, sleepiness, and so on. And the patient, in addition to the infectious endocarditis, the patient has anemia. Maybe this is an anemia of chronic disease due to inflammation in the heart, but also this may be an iron deficiency anemia. So let's perform the usual investigations and let's measure ferritin to find out if this patient has iron deficiency and if he needs the iron replacement therapy. Do you have any questions for this patient? Remember, please, that the infectious endocarditis requires intravenous antibacterial therapy, not oral therapy, especially in elder patients with immune reactivity. So let's discuss a couple of ECG. ECG is always good. We have analyzed this ECG and this and this. Aha, great. Let's analyze what is the rhythm. Irregular. And what is the source of rhythm? Is it sinus or not? Do you have any P waves?
No, atrial fibrillation.
Great, thank you. Yes, the rhythm is not sinus. We do not see any P waves. Instead of this, we see small waves resembling the shaking of the baseline. This is an atrial fibrillation. A common mistake is to say that there are multiple P waves and the AV block. No, there is no a condition with multiple P waves, and these irregular waves of different shape are waves of atrial fibrillation. So if we have no P waves, we cannot analyze the PR interval. So no PR interval. QRS axis positive, positive, and positive. So QRS axis is normal. QRS are not widened, they are narrow. As for the signs of hypertrophy, no big R in the V1, no signs of right ventricular hypertrophy. As for the left ventricular hypertrophy, the S wave is 10, 15, and R wave is 22. 22 plus 15 is 37. 37 is larger than 35, so this is a positive voltage criterion of the left ventricular hypertrophy. However, we should confirm this finding by echocardiography. And as for ST and T wave, it is abnormal. We see negative T wave from the V2 to the V6. And we see that this inverted T wave is rather symmetrical. Both descending and ascending parts are equal, and it is V-shaped. The V-shaped negative T wave is a sign of ischemia. Compared with the strain that it is asymmetrical, compare please this T wave and this T wave. This is an ischemic changes. We cannot say it more precisely without a clinical situation. If this is a clinical case when the patient is experiencing the heart pain at this moment of the ECG record, we can say about acute coronary syndrome without ST elevation. And if the patient has experienced the angina several days ago and now the ECG is recorded, we can regard it as the sign of myocardial infarction without Q wave. But without any clinical situation, please do not make any clinical diagnosis. Just describe the ECG. Based on this ECG, we can only say that this is an ischemic damage of the anterior and lateral wall and nothing more. No timing, no clinical diagnosis, not at all. So atrial fibrillation, voltage criterion of the left ventricular hypertrophy, and ischemic damage. And the second disease for today, because we have analyzed very difficult case about endocarditis. What is the rhythm? Yes, in this part. And what about this left part?
No P wave.
No P waves and waves of
Atrial fibrillation.
Yes. So these are two different parts of ECG: atrial fibrillation in the left and sinus rhythm on the right. This is a paroxysmal form of the atrial fibrillation. This is a paroxysm of atrial fibrillation. It is spontaneously terminated because we see no discharge of the cardioverter, and then the sinus rhythm is restored. Please look at this QRS. We see the negative P, so the rhythm is restored by the atrial rhythm, and then sinus node is activated and begins to work properly. PR interval is normal, and QRS are normal too. At the next lesson, we will discuss the ventricular tachycardias. So, at the next lesson, we will discuss gout, some ventricular arrhythmias, and what do you want yourself to discuss more. More details.
Cardiology.
Cardiology is very large. What precisely in cardiology?
Rheumatoid arthritis.
No, rheumatoid arthritis, rheumatic fever.
Yes, yes.
Yeah, okay. Let's discuss rheumatic fever. I will prepare you materials and clinical case. What else?
More on ECGs again.
Okay, a lot of ECGs. Yes, I will give you a website to practice more ECGs and to check yourself with a virtual exam, not our exam just for you.
Okay, thank you.
Okay, rheumatic fever. So think for the next lesson, because we will have two additional lessons optional additional lessons at the next week to discuss more and more what you want. So thank you. It was a great pleasure to work with you today and to receive your great answers. Thank you very much for your attention, and we will meet at Friday at our usual time. Goodbye to you.
Bye, Professor. Thank you.
Thank you very much.